Hello, my name is Laurent Brochard. I'm the head of the Division of Critical Care Medicine for the University of Toronto. I work at St. Michael's Hospital with Art Slutsky and Tai Pham. We work in the ICU and we also have a clinical research laboratory, and our main focus is about mechanical ventilation in general.
My name is Tai Pham. I'm an intensivist trained in France, and I'm currently a research and clinical fellow in Dr. Brochard's lab. In this article we wrote with Art Slutsky, we provide a global overview of the importance of mechanical ventilation, which is the most frequent intervention used both in acute patients in the ICU and in more stable patients in the operating room. We think that it's an exciting field and it's a very, very important procedure because it may look simple at the first look, but it's more complex than it looks, and it can have a real impact on the patient's outcome.
So if we very briefly look at the history of mechanical ventilation, we could go back many, many years ago. But the real date which we use for starting of modern mechanical ventilation is 1952 during the polio epidemics, and especially in Copenhagen, where a lot of patients were dying from paralyzing polio. And one young anesthetist trained in Boston thought that the only way to save the life of these patients is to deliver positive pressure ventilation in the lungs. So he performed tracheostomy in these patients, and they started to manually bag these patients to ventilate the lung, and they had a huge impact on the survival rate, which dramatically increased. So since that time, positive pressure ventilation is the reference technique for delivering ventilation in patients with respiratory failure.
And for many years, the main target of the clinicians were to normalize arterial blood gas in these patients to have a normal PO2, PCO2 saturation. But we later understood through animal studies first and then human studies that mechanical ventilation can also harm the lungs. There is a phenomenon of VILI, ventilator-induced lung injury, which creates inflammation in the lung and injured the lung. So in patients with ARDS, for instance, the functional lung is smaller than in a normal patient, and it's what we call baby lungs. And we realize that giving the same tidal volume in this baby lung will increase a lot the pressure inside the lung and harm the patients. So that's why it's recommended to, for instance, to use lower tidal volume, like 6 milliliter per kilogram of predicted body weight.
One of the reasons why we made progress in this field is because we realized that mechanical ventilation is a tool which can be used to make pulmonary function tests in these severe patients and get information that it would be impossible to get in a patient who is respiratory distress. To understand that, let's have a look at real tracing from a mechanical ventilation, what we can see on the screen of a ventilator. This is a tracing of a patient under volume control ventilation, and from top to bottom you see the airway pressure, the flow delivered by the ventilator, and then the expired flow from the patient, and the volume. If you look at the pressure, you see that at each insufflation the pressure goes up to a maximum we call the peak pressure. Then we stop insufflation for a very short time, and there is a drop in pressure down to a plateau. And we realize that this plateau is exactly the pressure in the alveoli. So it's the maximum alveolar pressure, the one which is at risk of injury for the lung. The difference between the peak pressure and the plateau is just related to the resistance of the airway. So we can make a diagnosis of obstructive lung disease, for instance. And the amplitude of the plateau is related to the compliance of the lung. So again, high plateau means low compliance, like in pulmonary edema or in acute respiratory distress syndrome.
So we were delighted to present this article to you, and we hope that will make the reader want to go further into details with our work. Thank you very much.
Thank you.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.